Welcome to the Reimagine Patient Engagement Podcast. This podcast aims to answer the changing dynamics in patient engagement. What role does technology play in the space, and what are the key initiatives and metrics each individual in the ecosystem expects? Let's get started.
So welcome to Reimagine Health. Today we have Lori Pearlmutter with us, and Lori has had an incredible career. Lori is the former director of population health at North Central Arizona Accountable Care Organization, and has a variety of really excellent expertise in physical therapy as well as quality. She's certified in population health quality management, and I'd like to take this opportunity to welcome Lori to Reimagine Health.
Well, I'm really glad to be here. I've been listening to the podcast and have found out some wonderful things.
Great, Lori. You've had such an incredible career, and your background is amazing, and especially kind of your work in quality, because I think that's so important today. Could you just give us kind of like an overview of your career and some of the highlights that kind of you'd like to just talk to our viewers about?
Sure. I became a physical therapist a while back, I say in the last century. But my career has been mostly in healthcare leadership. So early on, I started taking leadership positions at a university medical center, and then in Flagstaff Medical Center, I ran that department for 20 years, and that included physical therapy, occupational therapy, speech therapy, massage therapy. We had a pretty good inpatient, outpatient massage therapy program, cardiac rehabilitation, and wellness programs. And I did that for 20 years, and it was a wonderful experience with really dedicated professionals on my team. And then I moved over to doing some work in an ACO in Boston and kind of moved around a little bit to try to find a position that matched my interests, and ended up as the quality manager for a federally qualified community health center here in northern Arizona that at the time served 13 communities across the northern part of the state. I was the quality manager. I was also over care management, population health, our incentive programs, risk management, all kinds of different things. And then learned of the job in Prescott, Arizona, running North Central Arizona Accountable Care, and moved into that position. I recently retired from that position and have become an adjunct faculty at Northern Arizona University, teaching epidemiology and population health to the physical therapy students, the first-year physical therapy students.
Great. You've had an incredible career, and I'd like to really touch a little bit on kind of your work around the accountable care organizations. Your background, you have a strong background in quality, and I think when you think in terms of accountable care organizations today, it just brings quality. So could you shed some light on kind of what it's like to kind of run an accountable care organization, and it's really kind of some of the areas to focus on, especially like with quality in certain populations, and your work with federally qualified health centers and high-risk populations. How does that all tie in when you're working with accountable care?
Well, accountable care organizations, and hopefully the people listening have heard of them, I always say that they're the best kept secret in the country. They started with the Affordable Care Act, or Obamacare as people call it, and it was really a creative way to incentivize providers and hospitals and different healthcare organizations to work together to provide high-quality care while also saving costs. Because as we know, our healthcare costs are beyond control right now.
Right.
And so this was a very creative way to incentivize people on an individual level in terms of an organization to try to save money, because the incentive, my caveat is I ran a MSSP, a Medicare Shared Savings Program, which means if money is saved for our Medicare patients, then we receive part of the savings. It's based on a very complicated calculation, but I think in the 3 years, 2019, 20, and 21, we shared about 46 to 48% of those savings. And the savings are based on what Medicare calculates will be the cost of care for the particular population. And they do it based on a 3-year spend prior to coming onto the ACO, and then they look at how complicated patients are, what their needs are, some of the social determinants, what the area is like. I hope I'm not making it too simplified, but it is very complex, and it's based on what the expectation of spend is. And I came into healthcare as a young physical therapist when we started this whole thing of capitation, if anybody remembers that. And the idea, I actually, in my first year, was working in utilization review for one of the capitated systems, trying to decide if people should have therapy or not. And the problem with that is it was a good idea to reduce costs, but that's all it was doing. So, of course, it incentivized people to not provide care. And ACOs are not like that, because the whole idea is to provide care and to do a good job in prevention and keeping people out of the hospital, and out of things that could have been prevented. And they do that by requiring high quality metrics. And so this past few years, we had to turn in 10 quality metrics, anywhere from mammograms and colonoscopies to making sure that blood pressure is staying in a good range for people with hypertension, and assuring that people with diabetes have low A1Cs and things like that. And so the amount of providers we had was about 40 total, and that included 2 large hospital systems as one practice, and then many other practices across the board. We worked very hard to assure that they would do all those things. So one of the things we did was work with people on coding, so they make sure that they're appropriately coding, so that Medicare is figuring out the right benchmark. Is what it's called, how much it costs to provide care is the benchmark. But also coding helps assure that the patients get the proper care that they need, because if we don't know what their problems are, we can't address them. And the other thing we worked on was really closely monitoring their quality metrics, making sure that they were doing all these things they needed to do, and achieving the results they needed to achieve. And I'm just going to put something in here. A lot of people know this, but we were not the only group that was requiring quality metrics. Many of these practices had to consider Medicare Advantage plan metrics, Medicaid metrics, other insurance metrics, and just national requirements of metrics. And I don't remember how many it was, but in the hospital I was affiliated with, they looked at all the quality metrics required, and it was something like 60 or 70. So it isn't an easy thing to be in practice today as a provider.
Yeah, I agree. I think it is extremely complicated. But when you think about the simplicity of really providing quality care at a lower cost, I think that's amazing. And the work that the ACOs are doing is really, really amazing. I want to ask you a quick question on incentives. So when you talk about incentivizing, I just kind of want to stress this a little bit. I know that there's incentives for the provider, right, and for the system. What about incentives for the person with diabetes or the person with, heart disease? How does that figure in that?
That is an excellent thought and an excellent question. And I remember going to conferences where I learned that the best way to improve is to incentivize both parties, not just the provider or the clinic, but also to incentivize the patient. And I am not a complete expert on everything going on, but I know there are a lot of creative programs that are coming out through the Centers for Medicare and Medicaid Innovation. And I know that there are some ACOs, some of the ACOs that are larger and started earlier, that are allowed to incentivize patients. We did have the option in the last year to offer patients money for coming to their annual wellness exams. Small ACOs have it a little bit more difficult because we didn't have the robust help on our tech side to be able to manage all of that. We were very small in terms of the amount of administrative staff we had, which was good, but that limited us to be able to do these new kinds of incentive plans. But I do know that there are a lot of other ideas coming out that should help with that. And you're right. It needs to be a partnership.
Right.
But there's more to it than that. I mean, just as we all know, people can want to do their best as a patient, and the providers can want to do their best, but sometimes social determinants of health, environmental conditions make it very difficult. So there are many ACOs that are being incentivized to do other kinds of things. There's ACOs that are working on housing issues and food insecurity and all of that, all of those additional things that create havoc with our health.
You're so right. And I think COVID really shined a light on that and on some of the needs outside of the medical needs, that you have to combine those social needs with medical needs as well. That's great. Another question that popped in my mind is really kind of around technology, and you kind of touched on that. And when you said you had 40 providers within your ACO, and what are some of the technologies that you use to help the providers alleviate some of the burden of these 60, metrics that they have to, meet in order to get reimbursed or to get some of that shared savings? So can you touch on what technologies that you've had or used that were really the most significant or had the most greatest impact on not only your healthcare system and the ACO, but on also the people that you were taking care of?
Yes. I was thinking how, as you were asking that, I would not consider myself one of the complete experts in technology at all. I think one of our limitations is we had providers from all across northern Arizona, and some of them were in very rural areas in the northeast side of the state. And I can't remember now, but at least 15 to 20 different electronic medical records.
Wow.
And as you know, each one puts information in different places, and there's different ways to get the information. So that alone was a challenge. However, we did use a particular population health platform for our ACO, and so we were able to get a lot of the information through claims data and through, for some of our biggest practices, how do I describe it? Just information that would just kind of come in very quickly in every month to this population health platform, then would, put it into the right place so that we knew as much as we could know in real time, which is very difficult when you look at claims data and all that. We could get information as quickly as possible that we could get out to the practices, where they were with some of their preventative care, where they were with their testing and all that sort of thing. During COVID, and 2 of my 3 years that I was there were right smack dab in the middle of COVID.
Wow.
So the one-on-one teaching and being in the clinics were a little more difficult. But we were able to work with people and give them quite a bit of feedback. Our biggest hospital had a really great remote monitoring program through COVID, and they were expanding it into other areas when they learned how successful it could be. So remote monitoring that gives real feedback as to what's going on with patients can be really helpful. Having the data that's needed in as real time as possible is really important. And there's many population health platforms that can be used they're getting better and better in including not just the health issues, but the social determinants issues and all that sort of thing.
Absolutely. So important today. If I understand right, you did use kind of like outside vendors with different technology platforms to integrate with your EMR?
Yes, we did. And the ones that are coming, there's many of them. There's several high-level ones that serve large ACOs across the country, and they have the ability to do two-way communication where things can be shared with the chart if that's what the particular clinic wants or practice wants. And also they can get information from that practice. And again, one of the problems with our ACO is the information we got was often very late in the game. So we didn't know if we achieved shared savings till 9 months after the year ended. And like I said, some of the quality metrics, it was hard if they're coming from claims data because claims data can be 90 days.
Right.
So having these platforms that are sharing information, two-way communication from the chart into the platform and back to the chart, and also having people who understand how to use this. It's a very complicated system and also very new. You know, how we've only been working on this since, you know, early on in the demonstration project was in 2011. And then when we really started to move into large-scale ACOs, it was a few years later. And ACOs have changed a lot and requirements have changed a lot. And they've gone from one-sided, meaning there's only benefit, there's no risk, to being required to be on two-sided risk. So all of this is new and all of this is evolving. And I would tell anyone, listeners who are interested in going into this field is way open and it can use a lot of innovation and creativity.
Absolutely. And I think we see it changing every day. And I think today the emphasis from, especially when I was at Sanofi, I can tell you that providers need a lot of help. They really feel so burdened with everything that's going on. So anything or any technology platform or anything that could really lift the burden, they were pretty open to that. So how were your providers there feeling about technology? Did they see it as more work, more burden, or did they see it as really kind of relieving the burden?
Well, I think we had advanced providers because I found out over the 3 years that there were ACOs all across the country, including the hospital system that merged with us, that were still not even on electronic medical records. Mm-hmm. And I'm going to go out on a limb here and say that a little more than gentle nudging is needed. I think that it's hard for people to change. It's hard for all of us to change, and it's very scary. And you lose things, but you also gain a lot of things. And so when we were told, you know, meaningful use, we were required to go on to that. There were delays and delays and delays. I even remember when we were, one of the places I worked, getting providers onto electronic prescribing, which is much, much safer. And there were a group, most of the people, who got right on board. Mm-hmm. And then there were a lot who straggled. And I think we need to encourage, but also provide quite a bit of support. And that's one of the things that's scary to people. I'll tell you, it was scary to me coming on board to an ACO and having maybe a limited amount, you know, limited help with the tech side of it and limited knowledge. I think that, you know, we really have to have robust systems that help providers and not make their lives so much more difficult.
Right.
One of the things I used to say when I would apply for jobs, they weren't traditional physical therapy jobs, is I've been there. I have worked in clinics. I have had to fill out documentation forms online. I have had to do, you know, check all the boxes and follow up with everything. And it takes a lot of time. And I'm trying to treat a patient here, guys. And that's what the providers say. They really did not go into this to spend time in front of their computers.
Yeah.
So making it, you know, tech is important, but not if it just adds more and more and more on top of them to do each day.
Exactly. Great questions. And then I know we're running out of time, and I just want to ask one final question. In our conversation, you mentioned that a lot of the population or members of the ACO needed other therapies like rehab. Can you kind of like talk in more detail on how that kind of like worked out and how that data showed kind of that people needed kind of like extra care, and how did you kind of like execute on that?
So we didn't actually have any say in the care that was provided. And the quality metrics were all medical metrics, except I would say for fall screening, which was really kind of, did you fall or not? If you just asked a simple question, there was really no movement into requiring anybody to follow up with physical or occupational therapy or anything like that if they determined that person was at high risk of falls. And I think that would be a little difficult right now, and it would be difficult for an ACO a small ACO to follow up on that sort of thing. However, I do think some of the larger ACOs could have more input into that. So, for example, it's also possible to include skilled nursing facilities in an ACO. And that allows people to come out of the hospital as soon as they are, discharged any day. They can go into a skilled nursing. They are not required to have a 3-day length of stay. So that helps things a little bit, where people can get to the right facility quicker, but making sure that the team is there to make the right choices and that you have the right people at the table to make the decisions is really important. So those kinds of things I think can be done a lot better and a lot easier with a large ACO that can track all these things.
Right.
I'm biased. I want to see more rehabilitation because we know that many more people need rehabilitation than we think, and I'd like to see us more involved in the integrated, primary care team because I think it would be better for patients. But we're sort of making this shift from fee-for-service to value-based care, and I think we're all learning and we're figuring out the best way to do it.
Right. And it's not here yet. I mean, it's here, but it's not here. And I think that we still have a lot of work to do. But I think the whole idea of value-based care is, I think, going to really, change the whole U.S. healthcare system. Because right now, today, quality is really lacking. And we have to really kind of change that to really be more person-centric and really focus on quality and at a lower cost. And I think ACOs are doing it. And I think your work is amazing, and you've shared so many great things, Lori. We really appreciate you joining Reimagine Health, and really want to thank you for your input today.
Well, thank you for asking me. It's been delightful.
The bigger vision of Reimagine Patient Engagement is to build a community of healthcare transformers working to improve patient outcomes. Patient engagement requires patients to be in the circle of care to ensure that care is holistic and not as a snapshot during a moment of crisis, but as a view that is ongoing, continuously enriched and deepening over an entire lifetime. So, to be part of this amazing community and contribute to the vision, reach out to us at www.connectedcarecircle.org. That's www.connectedcarecircle.org.